Dexter sent out that email about shock, but like, it doesn't really fit with that pediatric code case, so I'll do that some other time. And so I just got a couple cases.
I don't think anybody that was on that PD code is actually here today. So.
Yeah.
You are?
I am.
You were here?
I am here.
I was like on scene, but I didn't actually get to do anything.
Trying
to go back to the station.
Yeah,
Oh,
I mean, it
Just out here
yes.
for 6 hours.
It works.
Yes,
they're
14,
pretty
10,
rare.
and 12, I can get
They're
into the
not
med
fun.
vault, now it's just the
No, it was not enjoyable.
paper.
No, just
Well,
everybody
they
shitting
were.
their pants. I mean,
The
I've
Knox
only been
box.
involved
Yeah,
in a
engine
few,
26,
handful of
service 40, and
pediatric
14,
codes.
I can't get into the keys.
Service forward
You know.
1, 2, 3, 4, because that's a backup.
I mean, bright side, nobody threw
So
out the
then I
back
guess I
end
can get into that
accreditation.
one. And he
That-
comes 6,
that's a
and
good
the
point.
MS 14 Knox box keys. Do
Okay.
you want me to send you an email?
There's always, obviously any code could have some like mental
I did
burden,
not
but like a
try
pediatric code
The squad track
Increases
yesterday.
that.
Yeah.
I think that we're able to
I
justify,
can't access it, my code
yeah,
doesn't.
we had that guy yesterday, we're able to justify it by like, yeah,
At
it's
least
hard
the
to
med
stop,
vault-
but
at least
it's
the
not
med-
because
at least
he
the med
did so
vault
much
works now.
drugs when he was
That's
younger,
good.
he just
I
burned
I
out
can now.
his
I
heart,
can.
and then he
I
died.
don't know about-
finally have access to everything.
Whatever, but when it's a kid, it's like, kid didn't do it.
Did you fix Ben's?
Kids
too?
innocent.
Kid wasn't doing drugs, kid wasn't eating McDonald's 4 times a day,
Uh,
like, kid's kid, right? So-
Kid's a kid,
What
and,
am I looking for?
especially like an infant, it's just like, just the optics and just looking at it, just. And then if the parents are there, I mean, I had a, case in residency where we were working a child for an hour, and then when we called it, the mom was in the corner and just, the screams she let out echoed with me forever, it just sits in your head. It's just, it's just different, so.
Trying to keep on the bright side, all the screams pretty much sound the same eventually.
That's true.
They all have
That's
that
true.
like blood curdling and then it like trails off to nothing where they can't breathe.
That's
So,
true.
At
You
least
guys
it's
are
just one
full of
scream
all
at
of
that.
You can only
bright and
scream so
sunshiny
much.
shit today.
Well, this isn't, it's a little bit heavier topic,
yeah.
certainly
Hey,
than,
CPA is
than,
not a very enjoyable subject.
I agree.
I'm gonna try and get that call on.
CPA.
I already spoke to my CPA this year. Right.
Personal assistant.
I'm not getting
Your
as much.
personal
I'm
assistant.
not getting as
Assist
much
you
money
all
as I
year.
want. Yeah.
Yeah,
Welcome to
well,
my
at least
world.
you're not paying like me,
That sucks.
1,200.
Jesus.
Ah.
Oh, I'll be around that.
Yeah.
5 or 3 times.
I usually get nothing.
Both New York
Paying
State and
taxes.
the state of
Yeah.
Maine are giving me double digits.
I worked a side job and I thought that I hadn't made enough, so I kept working more and more and more. And then I made too much and I wasn't paying enough in, so.
I wish they would just calculate that ahead of time. I still haven't figured that out actually.
Well, it's really confusing. The whole system seems to be working against you, right? Because every check that you make is taxed at 10%.
Yeah.
When in reality, the first, 12,500 is 10%, and then up to 23,000 is at 12, and then, 14 and so on.
Yeah.
You'd think that they would do that as it went, but no. And then of course, the government knows how much money you owe,
Yeah,
but they
But
won't
they won't-
tell
they
you.
won't.
Last year
So
we
you
came
have
out
to
great,
figure it
just
out.
right.
If you get it
We
wrong,
ended
you're
up
in
getting
jail.
about,
I know.
One-
That's,
And if you get it wrong and give them too much money,
And
then, oh no, that's okay.
less than
We'll take
100
the
back.
Yeah,
it's,
that's
That's
fine.
it's
And
just,
that's just where
it's
you
like
want.
it's a scam.
You don't want to get,
really.
if you're getting big money back.
Now we're thinking
overpaying.
76 logic.
Yeah.
Yeah, I'm usually,
I mean, it's
usually
just, I don't
right
know
around
how, I don't know how we
breaking
got
even,
to this
or I end
point.
up paying.
What was the tax percentage
It's
on the
usually
tea
always
that
the
they
same
flipped
name.
out about? It was something
Oh,
really low. It was like
it's-
7%.
It was small. It was that though, and I think whiskey though, right? Weren't they taxing whiskey too much?
Yeah, but even then, like
That's
the
a
tax
shame.
rate on that was like 10,
Ridiculous.
12%.
They should
Now
be-
we're at like 30, 35. Like I lose half.
Someone
the
should
third
get
of
a
the
piece
paycheck.
barbaric,
It's
but we're
just
doing
like,
it.
yeah, it's part of life.
What's that?
It's barbaric, but
Part
we're
of
doing it.
society.
Yeah.
There's
Just, that
a-
money just
it
goes
does have a
into,
streaming option.
a
I
black
just
hole,
haven't had the
right?
time to figure that
Doesn't
out.
always
It's not a
go.
black hole. It's Ukraine. I
Yeah.
think.
Some of it does go to Ukraine.
I think taxing should be illegal.
So, you just let me know,
Could be after Russia's.
I mean,
I guess
yeah, I
it'd
mean,
be
this
black
is,
hole.
I mean, we're just 8:58 actually, and that isn't even.
Oh, look at that.
really, but, yeah, however, you guys wanna do this. I agree, it's much better in person with that Zoom call. I wasn't quite sure, what was going on.
I believe the shift is coming in here.
They should be, yeah.
They were in a meeting. That's what I'm sure. We got
You guys were pretty busy last night?
Wow.
No. Oh,
Now we're stuck
now
from
you're being sarcastic.
midnight to 5.
No. Not bad.
Our call, what time was our call at?
I thought it was around midnight, because I was still awake, and when the call went out, I went, holy shit, I'm still awake.
Was it later? What time did we go at 11?
I don't know. And then we had,
Yeah,
we
we went
had
out at
a
11:18.
nonsense call at 5:30 this morning.
12:30.
No, I passed out when I stood up from the toilet, and I've got difficulty breathing at 98%.
He walked down into the hallway.
It's gonna cost 300 grand
Yeah,
to
so
replace
that-
our parking lot and our driveway? To repave it?
Yeah. Dude, paving's expensive. as
Paving's
fuck.
very expensive.
300 grand?
Yeah, because they can't just go over it, because then it'll just crack like it is, so they gotta tear all that up, they gotta regrade it, then they gotta put everything down, tamp it, put down another layer, tamp it, and then paint it. And
Yeah.
you're talking,
$300,000.
It's a lot, I don't know how much square footage you're talking
Gonna have
about,
to start
but
doing more
300
calls.
is,
it's all the
Jesus.
tar around the station.
oh,
So,
then yeah.
See,
That's a
big
ton.
guy.
Yeah.
Layer to layer.
Just to do my damn driveway, it's gonna be like $25,000.
Yeah, it's like 30K for just a typical driveway, so. Times 10.
The stretcher at Fairchild Monitor is 85 grand.
12 to 5 though is not bad, it's more sleep than I got. It was
It
on a
does
string
make
of nights and then trying to
$7.
flip back is impossible.
Yeah, I tried the Benadryl trick, you know, take Benadryl for an entire day, so you sleep through the day, and then that didn't help. I got up to almost 30 milligrams of melatonin at night at one point, and it was like, okay, I was useless until
Not
2
doing
o'clock the
anything,
next
yeah.
afternoon,
Yeah, there's a threshold with melatonin, I mean, at some point your body's just not metabolizing it, you're just pissing it out. Some of the docs, usually trazodone works, but, I don't know, Benadryl just makes me super drowsy.
What
And
did
then I don't
you
fall
use?
asleep.
Tried Seroquel one time, that
Yeah,
worked.
that does
But
work.
it made me
Alright.
feel like I was gonna die.
Yeah, there's no perfect
I
answer.
felt like I was having a
Barbaric
stroke, it was like the
Barbaric
most drug I've ever been in my life.
You mean just prior to falling asleep, or?
I mean, I like took it, and then I was sitting, like, doing a puzzle or something, and I stood up and I tipped over. And when I hit the ground, it was like I was falling onto a pillow. I was like, what the heck? And then I got up and I just couldn't get my bearings, and I fell into bed, and eventually I slept, and it was good sleep, but no, never again.
Good morning, Maya. How are you?
Dude, why do you have to say that?
Because he's always so suspicious.
Hi, Joker.
Are you having a good day? I can go out and buy you a comb if you like.
What's that?
I can go out and buy you a comb if you like.
Says the
You sure?
Have you seen your hair?
I'm getting a haircut
Have
today.
you seen your
I
hair?
need a haircut.
Oh my god.
Dude, you need, what, not Nivea, what's it for men? Just for men. Just for men? You need just for men.
No, that's.
Touch of gray, so it looks like you know what
The
you're doing,
top,
but you
not
can
the
still do
bottom.
it.
Calm down.
I think that Sense here is particularly.
This was a A and B conversation between me and the.
See, all your ways.
I'm not sold on it. It's a very different style of mustache.
It's two different styles, the mustache is one different than
Mustache. We see if
You're
it
one to
really
talk
is
about
that.
mustache.
Yeah.
See, you look better
I
with.
got rid of mine so you'd have a chance.
You didn't have a caterpillar, you had a freaking scroll
That's
tail.
everything, I'm giving you a
It's
chance.
a million ways to die in the West. What's that?
I feel like it would look weird with
Yeah, it's funny. Mustache.
That's just because you're bald and you don't know what it's supposed to look like.
Oh.
You've never seen hair before.
Not bald.
Is that for the?
Oh, no.
See,
Wait,
Zoom, I have one new life.
Yeah, I'm
Open it up,
trying to
there's
just tap
nothing
into
there.
this one,
Guaranteed,
and,
nothing there. You're a liar, Black.
I'm like, I was getting into this one.
Or you got the like and they unmatched you immediately.
No, it's happened like 6 times in the last hour.
no, feeling down. It just doesn't work too much.
They realized they swiped by accident.
Verify your identity.
Yo, shit, I meant to skip my first
Right.
Sorry about the delay.
No, no worries.
No worries.
I mean, I but like I'd almost rather just go out for dinner and drinks.
I have part of mine, they have to finish.
Just go to business directory.
I can't go on, no, we went out, my best friend's mom died the other day.
On the bottom there.
So.
Oh, no, it's not gonna take any.
And they bought us.
Derek, I'm sitting down
bottles of
for you.
wine that the table shared.
How's it going?
People.
I-
Which was fun,
I
and
think that
then in the back of the house, I drank.
Why are you so close to me?
And I didn't drink anything, but I just didn't feel it after. And then I slept in the house because when we came, I thought this time we went out in the hot tub. When I came back in,
All right, as I
I slept.
fiddle through this, we will get started, and I will work through getting this up and running, hopefully. Dr. Burla has been kind enough to do this last month. Well, 2 months ago, we did via Zoom. The intent moving forward is that every one of these will be in person, and we are recording. It's going to be put into Target Solutions, and then we'll be able to review it afterwards. The intent is going to be for main CEUs. I did not apply for today, but I'll get your info and we'll try, which they're not happy about usually, but we'll post apply for it.
We did this in the future.
It's just.
Yeah, so we'll try. I'll get a CEU sign up sheet going around so we do get some CEUs out of this. And the intent is going to be every other month. If you have ideas of certain cases, bring them forward. If they tie into a theme that Dr. Burla is putting a presentation together, please let us know and we can work through those if you get a good case and whatnot. Does anybody have any questions? Remember, you are being recorded, so I appreciate that.
So,
Yeah.
don't
I don't even know why you have to tell us that.
Right.
And as I get
I'm only here
this
for
set up,
He's targeting me.
I'll let Dr. Burla start.
So, to touch on the cases though, it would be useful, the more cases from you guys. I have a ton of cases of my own that I share with the residents that rotate through our department. But those are obviously from a variety of services, you know, Sacco, Goodman Wills, which are still useful.
Lesser departments. Got
There
it.
you go. Yes.
If we hit the requesting review on our reporting system, does that go to you or Chief, does that go to you?
Goes to me.
I was gonna
Goes
say,
to you.
I believe it goes to you, but you can email
I can forward
me
them.
on there's like that little email icon, and my email is just michael.burl@mainhealth.org. But that would be useful too, because then it would just end up
Yep.
right in my inbox. You know, with this particular subject, I mean, there's not a lot of pediatric code cases, which are going to be going over that one that occurred last month. So I included another cardiac/respiratory arrest case. It's an adult case though. I know in the email it said we'd be talking about shock, but I have a lot of cases for shock and the different types of shock, and I figured we could just do that some other time. So, so we'll be just talking about 2 cases today. Nothing to disclose, obviously. And just like last time, we're going to be going through the cases, a little pathology review, going over the management, prognostication, and you know, any feedback is welcome. I know last time kind of started with the case, went through some info about the disease process, and then returned back to the case for the hospital course and kind of the outcome of the patient. And if you guys want to continue with that, we can keep doing that. If you want to switch it up, just let me know. So, just to jump into it, this is the HPI, the history of present illness, from the receiving physician at Biddeford for this patient. So it was a 5-week-old female who presented in cardiopulmonary arrest, which essentially, you know, is a respiratory-driven cardiac arrest. I think he meant to put, unfortunately, details are fairly scant at this time, as opposed to fortunately, probably used Dragon to audio record his note. You know, and he mentions that there was an off-duty EMS officer who was able to initiate bystander CPR.
911 was called at that time. Per reports, the baby was born premature to a mother who had a history of cocaine use with some possible neonatal abstinence syndrome at delivery. The patient was intubated in the field, received 1 round of epinephrine, and was found to be in PEA arrest. There was a few attempts to place an IO, and apparently it wasn't functioning when they arrived at the emergency department, where they placed a few IVs. The PALS algorithm was utilized, and then they used a Browslow tape to further the management of the patient. And multiple rounds of epinephrine were given in the emergency department. This was his physical exam, which, you know, is pretty self-explanatory. I mean, the patient appeared pale, unresponsive. He validated ET2 placements. There was breath sound bilaterally, abdomen was soft, non-distended. Patient was cyanotic, you know, and lifeless. So before we get into the incident report, does anybody have any thoughts or, you know, on the actual case when the call was made? It sounded like there was an unknown downtime.
Not really.
Okay.
No, so my understanding was, do you know Biddeford at all?
A little bit, yeah.
So there's a stoplight before you turn into that mall area.
Yeah.
They were at that stoplight and she was fussing in the back seat. And they turned in and said, well, we'll take care of it, we're going to Target anyway. So they went in, and by the time they had gotten in front of Home Goods, she had stopped fussing and went, well, that's weird. And she was kind of making gurgling noises, so they stopped at that point, got out, recognized that she wasn't breathing. And one of our captains was walking out of Home Goods, or in the area anyway, and started CPR on it. So it was fairly quick, I mean, as far as codes go.
And per the report of the foster parents, right? I mean, they heard some gurgling and then they pulled over. And that, it probably was pretty quick, you know, and that's pretty much what was in the report. And, you know, I'd like to say that, you know, Dr. Meehan Cusay and the, you know, the physicians at Southern Maine were, you know, very grateful for the work you guys did, because, you know, these are always difficult patients, especially with managing such a small airway. It sounds like that was obtained very quickly. It sounds like, you know, there was a fair amount of secretions and formula in the airway, which probably led to the cardiac arrest, and which we'll talk about later on in this case. You know, pediatric cardiac arrest, unless there's some congenital heart defect, is usually respiratory driven. You know, and then we'll talk a little bit about some of the new AHA guidelines on management of pediatric cardiac arrest, but you know, everything was done as best as it could have been, it sounds like. You know, the PALS algorithm was utilized, IO axis was established, the vocal folds were visualized, and the ET tube was passed, which was confirmed in the emergency department. Received epinephrine pretty early on, which is, again, you know, something we'll talk about later on in this case, but is for pediatric patients, it's now recommended epinephrine be given essentially as soon as possible, or at least within the first 5 minutes. And then the patient was transferred to the emergency room at Southern Maine Healthcare. You know, it was reported the patient was in asystole, you know, and then converted to PEA arrest in the emergency department. And again, that's the majority of the initial rhythms with these pediatric code cases. So there's really no indication for shock and things like that. You know, I looked through the whole rhythm strip. I mean, it pretty much was asystole, especially given the scenario, you know. And so I'd go with that. I mean, one could argue, you know, maybe there was some fine VFib, but highly unlikely in a 5-week-old without any known congenital heart defect. So like last time, I kind of pulled up some of the main EMS protocol just to go over briefly with airway management. You know, again, with a pediatric patient, if there's no known congenital heart defect, respiratory-driven cardiac arrest is the first thing. Bag valve mask works really great if you're not able to attain an ET tube. You know, I know the airway wasn't failed, but you know, it's not horrible to have to go back to BVM if you have to. You know, as long as you're getting good response and not resistance. At the end of the day, you know, especially in a 5-week-old, that's really, if you're not getting the airway, that's all you really have, unless you're gonna do a needle crike, right? Because the anatomy of someone of age 8 or less, you can't do a true cricoidotomy. You have to just do needle, and that's extremely difficult to ventilate or oxygenate. You know, if airway was confirmed in the emergency department, in this particular scenario it wasn't failed, but if it was, you know, I wouldn't mess around. I would continue doing bag valve masks. And this is just discussing anticipatory efforts. Again, in a cardiac arrest, this is not you know, the top of priority with axiolysis, you know, with midazolam or ketamine, you know, but in somebody who you have ROSCON or who you know, wasn't a cardiac arrest patient in the first place, I mean, you're definitely going to want to get those medications on board sooner rather than later. And so, one thing I wanted to ask, I mean, with pediatric patients in general, you know, it's all weight dependent, weight dose dependent. In a pediatric code, I mean, there's all these weight-based medications, you know, you potentially could give. You know, in the heat of the moment, you know, given, you know, 1 milligram of 10 mils epinephrine, you know, isn't going to be the end of the world. I mean, the dosing is 0.01 mg per kg, but I mean, that's not something you're going to easily be able to calculate. I'm not sure. Do you guys have the capabilities to do that?
Yeah.
Yeah. Okay.
Yeah. The 10 ml syringe that comes in is just one of the little lines.
Okay, and that's just how you.
And just one little line is 0.01, and you can just.
We have three-way stopcocks to
Okay,
use with smaller syringes too if we need to.
All right. All right. And do you guys use Braslow's tapes?
Yep.
Yeah. On every patient, adults included.
Adults included.
You gotta make sure.
So to get back to the emergency department, this was the X-ray taken, and you know, for our purposes, when we confirm, I mean, you want the ET tube at least on an adult patient 2 to 5 centimeters above the carina. With pediatric patients, it really varies depending on the size. Obviously, a pediatric patient that's more adult size, you're going to go with that, but typically a rule of thumb is 2 centimeters is a good range to be in, and that's kind of right where we're at here. The lungs appear clear. The x-ray is otherwise unremarkable. This was the EKG that was done post-arrest. It wasn't actually done at Biddeford, it was done at Maine Medical Center. I mean, at Biddeford, they really tried to get the patient out, which makes sense, right? There's no PICU there, there's limited resources. You know, in this type of patient, I mean, you're certainly looking for arrhythmias or other abnormalities that could suggest maybe there was something congenital with the heart that just wasn't picked up at birth. But this is an otherwise normal pediatric EKG. You know, you've got P waves before QRS. These kind of biphasic T waves. You can see that in pediatric patients. It's not, not a true abnormality. And there's no, large, wide QRS or something else that suggests abnormal anatomy of the heart. So this is back, the medical decision making. It was Dr. McKee, I believe, who primarily managed the case. And just mentioned, ROS was achieved, CPR initiated at 12:45 p.m., ROS was achieved at 1:35 p.m. And that the patient was hypothermic coming in, temperature of 92.8 rectally. And there was a active thought to not rewarm the patient because of the possible neuroprotective attributes of being cold. I mean, hypothermia hasn't really been studied great in pediatric patients, but from what we know from adult patients, probably should still keep them cool or at least avoiding fever. And it sounds like they contacted the PICU rather quickly, which the PICU physician made recommendations that we'd all think about: avoiding hypoxemia, keeping the end tidal, CO2 35 to 45 range, placing an OG2. Things we'd all think. There was a discussion about doing bicarb with the acidosis, or starting steroids for the possibility of cerebral edema. Bicarb in these type of patients, if you're able to get an airway in and ventilate them appropriately, bicarb's not going to do anything. And so I know in this situation they didn't end up giving bicarb. And in regards to steroids for cerebral edema, it can be neuroprotective, but it's not a cure-all. And so they didn't end up giving steroids either.
Would the steroids be that common that early
To give them?
to give them, or would they wait till they're stabilized a little more?
No, it's better to give it early than not. So even before, you want to give it before the cerebral edema takes place. There's something called reperfusion injury. After both with the heart and brain, but after there's an area of ischemia, once the oxygen rushes in, it can set this whole inflammatory cascade, just like an inflammatory cascade anywhere else in your body. But in your brain, it's not great because it's recruiting cytokines and inflammatory markers that are causing permeability of the tissue, which causes swelling. And the steroids are thought to help prevent that swelling because steroids reduce, all inflammatory cascades. So you want to get it on before all that swelling starts, to be honest. And so it makes sense to give it early, but I wasn't part of the conversation, and I'm not sure if the PICU attending was just worried about the downside of the steroids with glucose management or other things. But yeah, typically you want to give it early. And in fact, sometimes when we have head injury patients, we're going to intubate, give it ahead of time to try and prevent the swelling after the fact. Yes.
Is there any impact on the efficacy of the drug with the patient being hypothermic?
Yeah, actually. A lot of drugs don't work great when the patient is super cold, especially with poor circulation. And so it could just stay locally wherever you injected it and permeate to that tissue. Anybody else have any other questions?
I was you talked about it earlier. In the physician's notes from Southern Maine, it said that the patient came in with no access and they tried another IO and then ended up getting hand IVs.
Yeah.
And then in the EMS narrative, it said they had an IO established. Was that IO not patent when they arrived?
So it sounds like it wasn't. I'm certain that when the IO was placed, it was functioning.
Mm-hmm.
The problem with a 5-week-old, is the tissue and the bone, everything's fragile. So I don't know if
it was my understanding that for IO access on like infants and very small peds, distal femur is like you get more bone there.
You do.
Which is more like effective for them. Is that correct? or?
Yes, no, you do. You still can do the tibial, and they even, mentioned they tried the humerus. You kind of go everywhere if something fails. I know it sounds like they did tibial though, which is not wrong,
So you're our med control now, right?
Yes.
So in our protocol, we don't have femoral IOs. How bad are we gonna get in trouble if we do one on a Pete?
Well, I think if you initiate, a tibial and it's not functioning, I don't.
Call for it.
Yeah, you shouldn't call med control, but if I was on med control, I would say yes, do it. I know things are heavily protocolized and it makes sense, but when first and second option don't work, you gotta do something. And so, yeah, I would say.
Um, Steve Shostak, who is via Zoom, has placed it. He was trying to talk, but apparently we're not getting anything from.
I see him, I see his face.
Now, that's too much.
Our apologies for that.
Oh, that's much better when
I don't
it's
know.
black screen. Speak up, Steve. No, barely, wait a minute.
Oh, my ear.
I'm gonna text him, wishing him
Oh, it's all the way up the volume.
It's the laptop speaker, so.
Yeah.
You're gonna have to scream your question.
Go ahead, Steve, try again.
I'm the one that placed the IO, and it was functioning in the ambulance. I believe it came dislodged when they tried to push the Narcan through it every ED.
Okay. And that makes sense. It's a 5-week-old, so the bone's friable. It's not gonna, with transport, it's not gonna always be perfect. So, I think every ED doc documents differently. McKee's very meticulous about everything, and probably just wanted to make that known as to why, other means of access were made. So.
They push Narcan?
That wasn't actually documented.
I didn't see it in the
but it's-
notes.
Yeah, that wasn't documented, but, if that's what happened,
In the ED, they did push Narcan.
okay.
Was this 5-week-old a suspected junkie?
Mom had,
Because
mom
mom-
had cocaine.
Because mom,
Yeah.
She was born on opioids.
Thought she was born on cocaine.
I think the mother actually was a polysubstance abuser. Now, again, in the heat of the moment, if that's a last-ditch effort, I could see that, but the likelihood of that, doing anything, especially with the report given, the patient was with the foster parents, any sort of effects of, opiate exposure in utero, that lasts certainly, but, they have withdrawal after being born, and you have to treat it for several weeks, but, go ahead.
Peds aside, what is your opinion of Narcan in a cardiac arrest? Because as a department, we've been moving away from it, being that Narcan is trying to reverse the effects of your respiratory drive, and other than that, it has no effect, which if they're in full arrest, they don't have a respiratory drive, and they're not gonna get it back if we give them Narcan. So we've pretty much stopped doing that,
Yeah.
because it's not a very,
Yeah.
you're trying to fix a flat tire when you just put your truck in, it doesn't make any sense.
No, you need plastic. You're right. You need to put a tube, down their throat while you're performing CPR and trying to get the heart back. I agree with that. Now, am I going to fault anyone who comes in and gave Narcan to a cardiac arrest patient? No, but I agree with that statement. I don't think you have to. In fact, it's really not indicated. For instance, when we have someone who's brought in undifferentiated cardiac arrest, that's not what I'm doing. Pediatric cardiopulmonary resuscitation. Like I mentioned earlier, kids are different. The AHA really likes to make a point of this. Mentioning cause of cardiac arrests in infants and children differ than adults, and a growing body of pediatric specific evidence supports these recommendations. Essentially, all the literature out there, says things that we kind of would assume. Kids don't have heart disease, you know. They don't have some of these other comorbidities that predispose adults to having cardiac arrest. A lot of it's respiratory driven, unless somebody has a known congenital heart defect. And even in that case, like your typical atrial septal defect or ventral septal defect, you know, a little hole between the ventricles or the atria, those congenital heart defects really don't have much effect either. It's like the bigger ones where it's like the transposition of great vessels and coarctation of the aorta and other things like that really mess with the anatomy. And so we're going to kind of just focus on some of the newer recommendations they made and kind of just reviewing pediatric resuscitation in general before we get to, you know, the patient's hospital course and what they found. So more than 20,000 infants and children have cardiac arrest in the United States each year. The AHA makes a point that, you know, in-hospital arrests actually have pretty good rates of neurologic outcome and good rates of ROSC, which, you know, can't be said about out-of-hospital cardiac arrest patients, specifically in infants. And, you know, comparing the two populations, you know, why do you think that is? Like,
Right.
why would the in-hospital have better?
Recognition.
Say that again?
Recognition.
Yeah.
Someone's
Right.
gonna recognize an arrest in the hospital.
And they're gonna do CPR immediately and take over the airway immediately, and, you know, these kids generally have healthy hearts and things like that too, so if you get immediate ROSC, they should be fine, right? You know, the one things with peds, particularly in infants, is, I mean, they have very little reserve. You know, an adult, you know, good healthy adult with healthy lungs can remain unoxygenated for several minutes, and you know, once you get the oxygenation back, I mean, they can recover pretty good. An infant, after a few minutes, I mean, the brain's already going through ischemic changes because they just don't have that oxygen reserve. You know, the AHA also mentions, and you know, I talked about this earlier, maximize chance of good resuscitation outcomes. Epinephrine should be administered as early as possible, ideally within 5 minutes. The start of cardiac arrest for non-shockable rhythm, asystole or pulseless electrical activity, PEA. I mean, and that's typically the electrical activity, or what you're going to see on the rhythm strip. You know, prior to this, and I think it was like 2015, up until 2015, which was the old recommendations, was just simply to consider administering epinephrine in a pediatric cardiac arrest. Again, it's based on, you know, the lack of literature, right? Even with adult patients, epinephrine actually really hasn't been shown to improve outcomes in cardiac arrest patients, and so PEDS has even less literature to you know, back recommendations. But you know, with everything that we've learned up until now, it makes sense to just administer the epinephrine. And then the final, like, key update, and these were all updated in 2020 and 2021, by the way, just to give you some context. Based on newly available data from pediatric resuscitations, you know, the recommendation of breath assisted ventilation rates is 1 breath every 2 to 3 seconds for all pediatric resuscitation scenarios, as opposed to 1 every 3 to 5 seconds. Is this something you guys are familiar with, or, yeah, so. H's and T's for PEA, assuming you guys are all familiar with this too, right? Mm-hmm. Specifically, so, I mean, we don't have to go through all of them for PEDS. Hypoxia, toxins, you know, are the main ones, you know, we got to consider. Certainly, if a pediatric patient is sepsis or things like that, hypovolemia, or you know, if there was peach trauma, you would consider that too. But this has got to be number one with a bullet, and then certainly with history, toxins. You think about, I mean, there's plenty of one pill kill scenarios in small pediatric patients. You get a hold of beta blocker or you know, whatever else, adult medications that could kill a small child with one pill. This is just the PALS algorithm. Again, The resuscitation was followed to a T. You know, mentions all the things we already talked about. So we'll just kind of go through those. You know, they include for pediatric tachycardia pulsus algorithm, narrow versus wide complex, which I think is only relevant, you know, once you get a pulse or can palpate a pulse. Other than that, you're really going back to H's and T's as to why someone is in PEA. And then this is just a demonstration of the Broslow tape, which pretty rudimentary one. Oftentimes they obviously include medications and dosing for those medications. So again, just to go over the basics, infant who's pulseless or is less than 60 beats per minute, I would begin CPR, monitor defibrillator obtaining access. In a child, the carotid or femoral arteries are the most reliable method. I would say for infants, it's brachial is by far the best place to palpate a pulse. You know, and as we know, you can't feel a pulse within 10 seconds. CPR should be initiated, or you know, sooner if you have a high suspicion for cardiac arrest. Chest compression should be initiated at a rate of 100 per minute, depth 1/3 time anterior posterior diameter of the chest, and should be initiated before ventilation. I mean, the sooner the better, obviously. You know, effective chest compressions is key. You got to make sure the chest recoils, as we know. Certainly, again, we go back to children and the fact that respiration or respiratory arrest is the leading cause of cardiac arrest. So you do want to kind of get on the respirations sooner, but chest compressions is still paramount. These are just examples. I mean, ideally, if you could do the two-hand compressions, that provide a little bit better response, but you can do the two-finger too. And you guys are all familiar with the IO axis. So, in conclusion, with at least this review, you know, pediatric cardiac arrest is often due to respiratory arrest. Recognizing earlier, the sooner the better. You definitely don't want to interrupt compressions or ventilations to obtain access, but with multiple people working, I mean, you should be able to achieve it. And to reiterate, I mean, the patient should be receiving both chest compressions and ventilation, because you know, that's really the key to getting ROS with these patients. You know, oftentimes it's not the epi or other interventions you're doing unless there's something specific going on.
Doc,
Yes.
on the IO, I've heard some people say that rather than using the drill with pediatrics, you should just use it like an old jam sheety and use it that way because you get a better feel for when you actually get into the center of the bone.
The smaller child, the better. Now again, if your muscle memory is drilling the last 20 IOs you did, and you're not necessarily feeling comfortable doing that, I would still drill, but you will feel better because the bones are like, you know, rubber. I mean, they're not like our bones. So, yeah, I mean, you're gonna get a better feel for it, you know, if you feel comfortable. Yeah, yeah, it's just, you know, it is what it is. But that's true. I mean, you know, the IOs I've placed in peds patients, I mean, I just drilled to skin. I didn't necessarily feel anything. It was really more about how it flushed and pulled back, and you get some bone marrow and it's in. So, any other questions or thoughts about that? I know that's all pretty basic stuff for you guys for the most part. So this is some things taken out from the patient stay at Maine Medical Center. You know, it was a witness. You know, they documented it as a witness arrest. I would argue, you know, the time between when the patient started making gurgling noises to pulling into the parking lot was paramount, right? And perhaps there was an unwitnessed component, because it's not like someone was right there and immediately started trying to resuscitate the patient. You know, they pulled in, they found the patient unresponsive once they, you know, got out of the car. So, I think that's the key to the outcome of this patient. But they, were intubated, brought to Southern Maine, transported to Maine Medical Center. Once they got to the PICU, they were put on continuous EEG, had a head CT done. They had some episode of hypotension when they went to Maine Medical Center, and they had some seizure activity. They initiated phenobarbital. They did an MRI of the brain. Based on these findings, they had a family meeting. They decided to transfer the patient to a do not resuscitate status, and then discussed further about goals of care. So during the patient stay, the patient was in the hospital for 10 days. They had an initial head CT that demonstrated low attenuation areas in the putamen and the ventral thalami, which were concerning for infarcts. They did an ultrasound of the head that they do through the fontanelle to assess for any sort of intracranial hemorrhage, which was negative, but again demonstrated the ischemia. The next day they ended up doing the MRI because the ultrasound didn't show any sort of swelling. And the MRI was pretty damning. It showed, diffuse hypoxic ischemic injury involving the supratentorial brain, as well as the cerebral cortex, corpus callosum, basal ganglia. Essentially the whole brain. And they demonstrated diffuse edema with the MRI. The patient ended up having some lower extremity swelling, which is why they did the ultrasound, which was negative. And then they repeated the ultrasound of the head 5 days after to reassess the brain injury, which then demonstrated worsening of edema with diffuse cortical edema all through the brain.
You say no trauma noted though, so it wasn't like a shaken baby issue type?
Yeah, wasn't like a shaken baby issue. And then sometimes with the edema, you can get some associated bleeding too. They're really trying to assess the, so they do continuous EEG on these patients. The interpretation of the EEG is pretty, let's say, not super useful unless you're in conjunction with imaging and physical exam. They get these suppressive bursts that are very non-specific. Like the brain's maybe doing something. It's not a normal brainwave activity, but it's there. And so they go through a whole series of imaging to try and assess the actual viability of the tissue. But yeah, you're right. They were not concerned about any sort of shaken baby or anything like that. So this is the head CT. Unfortunately, the MRI was not pulling up for me no matter how many times I tried to do it. But what they're talking about is this, low attenuation is all right here. So these are the ventricles. They're going to be low attenuated because there's cerebral spinal fluid. Any fluid on a CT scan is going to appear darker. There's less attenuation. There's less mass there, right, for the waves to go through. And so this is just dead brain tissue. So this is just kind of a review of the neurologic status. They recommended, or they mentioned at 72 hours post-arrest, the patient was behind, I should have blurred that name out, but patient is behind peak cerebral edema, decreased risk for herniation. So she didn't get to the point where her edema was so bad that she was going to herniate through her skull. But there was enough swelling there to cause brain damage. At the time they were questioning the neuro exam with some reactivity of the pupils, some irregular breathing. They still mentioned the prognosis is very poor, but because of some of those things, they decided to watch the patient for a few more days and get their repeat head ultrasound. So this is just to go over the brain swelling. you know, as most of you probably are aware, I mean, the brain sucks up a lot of the oxygen we breathe in. You know, on average, it's only 2% of our body weight, but it consumes 15 to 20, even 25% of total cardiac output. The brain has no inert energy-saving reserve, so, you know, other parts of the body, you know, there's fat and other things that can be broken down for energy. The brain doesn't have any of that, so once the oxygen's cut off, I mean, the brain is the first to have any sort of damage, which, you know, obviously can become permanent. You know, once the brain does achieve reoxygenation, like I mentioned earlier, you can get this reperfusion injury phenomenon where all the inflammatory markers that cells send out when they get damaged get released, which recruits immune cells and increase cellular permeability and have the fluid in the cells leak to the outside, which causes the swelling, and it's just a, you know, kind of and then which causes more inflammation, and so it's a vicious cycle, which increases intracranial pressure with all that swelling, which the body is like, hey, I'm not getting enough blood to my brain, so I need to increase my blood pressure, and that's how you get this compensatory hypertension, which doesn't really help. And so in a lot of these cases they allowed for permissive hypertension, but you don't want the blood pressure to get too high because it's just increasing the pressure of the brain and causing more cell damage. So this patient actually was placed on nicardipine when this occurred. She had the cerebral edema, her blood pressure got too high, they placed her on nicardipine drip to lower her blood pressure, vasodilator, which is, you know, what we usually do in any sort of concerns for intracranial hypertension. And this is her discharge summary. So, you know, they do mention the cardiac arrest of uncular etiology. You know, they did do an echo when she came in to look for congenital heart defects. It was normal. As we showed earlier, the EKG was normal. She had the initial head CT that showed the brain ischemia, which was confirmed by MRI. She had worsening of her cerebral edema over 72 hours. They repeated a head ultrasound that redemonstrated the cerebral edema, and she was declared brain dead. They consulted a second pediatrician or pediatric intensivist at Boston to confirm this, and then when they did that, they transitioned the patient to comfort care and withdrew care.
Did they end up doing an autopsy?
So I believe they did, but I don't know if that was actually concluded yet. They didn't document it at Epic. All I have is access to Epic.
Right.
The other thing I was looking for is if they, you know, donated any tissue, which there was no gift of life note either, which there usually is.
That's what I was gonna ask, was there any chance of a harvest candidate?
They didn't document it. I mean, I think there would be, you know, there's plenty of good tissue in a 5-week-old, but they didn't document it, and usually they do. So I thought that was a little odd. And they didn't document why it wasn't documented. You know, usually if somebody's not a candidate, they even put it in the discharge summary. They didn't document it.
What was it? What was it? NEHS?
NEHS.
At the end of it said something declined. NEDS? Is that?
Oh, I saw that, yeah, NED.
I don't know, actually. Notifying the decline. Oh. That's not medical examiner. I don't know. New England. Maybe that's, I don't know what that is actually.
Donation services?
Donation what?
Services, I don't know.
Is that what it
I don't know
is?
for sure.
Yeah.
Just out of, thinking outside the box, is there any chance because it was a state? Maybe? Because it's DHS involved, probably it was an emergency, probably took a break and.
Oh, yeah.
That's New England Donor Services.
Her custody is the
What is it?
state.
New England Donor Services.
Yeah, that's a good point. Is that New England Donors? Okay, so there was no donation.
Is that, I mean, sometimes that's, I mean, I don't know if that's true, but it's a whole different ballgame when DHHS is already involved.
That's a good point. Yeah,
Something I've been curious about for a while, actually, when somebody has that many meds put into them over a long period of time, would they be, or not be a candidate for, donation because they're just saturated with a bunch of different stuff? I mean, you put something like that into another patient, you're basically giving them all the meds that they had just been given.
Right, if the patient has a healthy liver and kidneys, it shouldn't be an issue, because they're gonna metabolize all of it. And I didn't put up her blood work, but the blood work was all fine. Her kidney function, her liver function was fine. She didn't have shock liver, she didn't have kidney damage from this cardiac arrest, so, you know, if those things are the case, they're all fine. Now that I'm thinking about it though, is, yeah, I mean, because being born from a substance abuse, I'm just wondering if maybe that's why they declined, you know. So that's probably the case. Usually it's a little, you know, usually in the discharge, you know, if they were gonna decline, it's a little bit more than this, because Gift of Life will put in a note, but either way, that makes more sense. You guys have any other questions about this patient?
Anybody check in on foster parents? I mean, that's pretty tragic. I mean, for them, they're doing this for a service to hopefully adopt, and how are they doing that?
So you know, from the hospital, from Southern Maine Healthcare, I don't believe so, but the notes from Epic, it does show that, you know, the chaplain, another like social worker too, were giving support, and there was a plan for therapy as an outpatient moving forward, but I don't know if that was fulfilled, you know.
I'm sure it was, yeah.
And I would hope so, because you're right, I mean, it's tragic for everybody, you know, all around. Was there like a debriefing done after this, this case?
Diffusing directly afterwards. So they brought everybody in that was involved in the call and sat here and talked about it. We haven't done debriefings in a while. We've moved towards diffusing and then letting people kind of handle stuff on their own. So getting everybody on the same page about what the call was, and then
we'll let everybody say what, yeah. How long do those usually take?
depends on the call.
Okay.
This one, a couple hours.
Okay. All right. Yes.
In terms of the brain injury and the permissive hypertension they were doing, you had said that the blood pressure got too high for that. In terms of infants, how high is too high with the blood pressure, or is it more so or less so than adults?
So nobody really knows. Even with adults, the literature is mixed. You get different intensivists wanting different blood pressure targets. Typically speaking though, to try and prevent worsening of cerebral edema and be neuroprotective, you want to keep the systolic below 180. Between 160 to 180, you don't want to get too low either, because of the increased intracranial pressure, if it's too low, you're not getting any perfusion. So you kind of want to keep it between 160 and 180. For the pediatric population, it's dealer's choice. You know, I think if you're creeping above that 180, just like an adult, that's way too much. But there's no good literature on it.
There's not much we can do if they're creeping up like that either, unless we're the cause of why it's going up. But I mean, there's.
And this is all like after the fact.
Yeah.
I mean, this in the acute phase when you guys are seeing the patient, like it's this is all sequela of the arrest. You know, in the acute phase though, I mean that's where, you know, the money's made. I mean, that's how you prevent you know, brain ischemia. That's how you prevent bad neurologic outcomes. You know, getting on the chest fast. I mean, again, you can only do what you can do when a call's made. You know, but chest compression sooner the better, meds the sooner the better, and in case with pediatric patients, ventilation the sooner the better. So, you guys ready to move to the second case? All right. So this was by Goodwin Mills, and this is a case I saw, so I could, you know, speak on it. It's an adult patient. they don't have the age listed here, but it was a 78-year-old female. She had a sudden onset of shortness of breath, which was found at scene. She had SpO2 in the 70s. They placed her on BiPAP. She got to 85%. It was also hypotensive on scene. They were getting reports of like systolic in the 70s, but when she arrived to the emergency department, she had like a systolic of 150, diastolic of 123, which I don't know how much you believe that pressure. So she had a history of hypertension, hypothyroidism, essentially came in respiratory distress. She had a hard time breathing, so I got mostly a report from EMS where it kind of just came on suddenly. She denied any, was able to talk to me a little, denied any recent medication changes, no known recent illness, wasn't having chest pain, abdominal pain, fevers, vomiting, no other symptoms. She was pretty tachycardic. She was tachypnic. She had both bronchi and rales on exam. Her lungs just sounded super wet. But she wasn't pale. She wasn't diaphoretic. She was just having a really hard time breathing. So you guys have any thoughts initially about her respiratory distress? I mean, what could be causing it?
Pneumonia, acute pulmonary edema.
Yeah, pulmonary edema.
Does she have any cardiac issues? Anybody do 12 lead on her?
So a 12 lead was done. And
That's not nice.
it is, yeah, it's not nice. Why isn't it nice?
Looks pretty complete bundle branch block
Yeah.
of some sort.
Yeah, she's got a
Most likely left.
bundle branch block. She's tachycardic. With left bundle branch blocks,
This sounds familiar.
you get worried. You certainly, a new left bundle branch block, we do get worried about cardiac ischemia. We get worried about, an MI equivalent. Now, cardiologists and typically poo-poo it as like a true STEMI. But it means there's some ischemia going on with the heart. It's not good. They wouldn't take this patient emergently to the cath lab for it. Now, certainly if she had some Scarbosa criteria, you would consider it, but she doesn't have any of that, right?
Was that like
No.
4 millimeters and 3 leads or something?
So there's
I can't remember.
there's the initial Scarbosa criteria that had 5 points, and then there's a modified with 3, and it's the 2 main ones to think about are concordance and decordance in the anterior lateral leads, V2, V3, V4. Concordant, discordance, concordant, I can't talk right now. If the ST segment is going opposite of the
QRS?
the QRS, you're going to need 5 millimeters of decordance. If it's concordant, so it's going down, which is way worse and way more concerning for ischemia, I think you only need like 3 or 4. I don't have it completely memorized, but if you saw this segment going downward, pointing downward along with the Q wave, then it's very concerning. You would need 5 millimeters of ST segment from the baseline here to be concerned, and even then, it's not as concerning as if they're both going in the same direction.
The Irish never believe us when we say we've got a STEMI anyway, so it's.
They don't. Does that make sense though? I know that the description was a little tough because I can't speak, but.
I guess every time I look at Scarbosa or modified, I just get a headache. But if that's the main thing to look at, is just the concordance or discordance of the
Yeah, concordance or discordance. Concordance, I mean, if they're going in the same direction, that's really bad. That's what I would look for. That's what I look for. I don't have the Scarbosa criteria memorized, to be honest with you. I mean, we just don't see it that often, and if I did see something concerning, I'm just gonna look it up while I'm there, right, to confirm. And then I'm gonna have to argue with the cardiologist, but either way, it's not a good looking EKG. That was the chest X-ray.
Yeah, so it isn't just us.
So I look at that.
You guys argue with them
Yeah.
also?
Yeah, oh yeah. It's like pushing out, really. So,
Boldface told that the story doesn't matter.
ah,
What?
yeah, you get depends on the time of day, how they want to respond. Either way, this is her chest X-ray, you know. So, I mean, you guys probably only look at chest X-rays when you come into the department, right? You don't look at them too often, but what'd you say?
Looks a little full in the bottom.
Yeah, this is full AF. I
Is
mean,
that
this is
fluid around her heart?
so. You know, to look for pericardial effusion is pretty tough on an X-ray. You're going to look for cardiomegaly. This is fluid all around the heart, but it's all in the lung parenchyma. And what'd you say?
Hold on, he was calling and telling you you're wrong. You started too early.
And another thing to note here is, you know, usually this should be darker, right? This should be darker. Air is, you know, the X-ray waves shoot right through the air. They don't bounce off of it. You're getting a lot of fluff here. This is cephalization of vessels. I mean, it just means that there's fluid all up in here. So
That explains BP though.
it does. It does, right?
Because of narrowing pulse pressures.
Yeah. This is just the interpretation from the radiologist, which we don't, I mean, this was later at night. We actually have to interpret our own x-rays without their reads in the middle of the night, so this didn't come till the next day, but it just confirms what we see. What'd you say?
Oh, he was talking about pneumonia. I said maybe it was a pneumonia that developed.
Yeah, I mean, it could be. Increased left base density, development of inflammatory infectious changes. I mean, they also mentioned increased interstitial vascular markings, may represent congestive heart or congestive failure. And then it says they known mass in right lung base, again identified. Which, you know, when she came in, I don't know if she didn't interact with the medical system too much, so they must have gotten that from another. You know, the radiologists have access to whatever imaging done on the patient, and they must have got that from somewhere else. You know, this is my medical decision making. I mean, the lab work illustrated elevated troponin, elevated pro-BNP, elevated white count. You know, everything was abnormal essentially. Like was stated earlier, she was switched to the BiPAP. She had a systolic in the 200s and was really having a hard time oxygenating, even on the BiPAP. I did a bedside ultrasound. I had a diminished EF, and so we started her on nitro. We gave her some Lasix. It improved her breathing a little bit, but after probably an hour or so, she started to get worse. You know, and her SpO2 went back into the 80s. ABG demonstrated a low PO2, which, you know, you would assume since she's not oxygenating well. So she essentially pretty much stopped breathing at one point, became obtunded on the BiPAP. So we intubated her. Shortly after intubation, her pressure dropped. After a period of time, the patient actually went into cardiac arrest, roughly 5-10 minutes after we intubated her. We did 2 rounds of CPR, we did epi, we did calcium bicarb. Now, the reason we did calcium and bicarb is because of the concern that was a cardiogenic component to both her shortness of breath and her cardiac arrest. And so it was just to protect the myocardium. We achieved ROSC, we placed her in an ORV drip. She became febrile, we initiated a cooling protocol, and then she was bradycardic. I repeated the ultrasound on her heart, she still had a diminished EF. Repeated the EKG, still was a left bundle branch block. Called up to the cardiologist at the intensive cardiac unit at Maine Medical Center because I was concerned that there was a cardiology component to her, both her respiratory distress and arrest, where they then kind of hedged and said, no, I mean, it's might be cardiogenic shock, but there's probably an infectious component going on. So they declined the patient's and referred me to the medical intensive care unit, who accepted the patient, but of course they had no beds, so she remained in our emergency department for the time being. And at that time, we were able to maintain a MAP of 80, and she was oxygenating okay at that time, so it was okay. And I admitted her to our ICU. This was just the chest x-ray after placing the central line. You know, they did put arrows here after they read it. I know it's a little tough to see here, but what do you think those arrows are referring to? This diaphragm is lower than this diaphragm. This is kind of clear here.
The pneumo?
Yes. So after the chest compression, she developed a pneumo.
Question, in your narrative, it said you guys gave calcium and bicarb within the first couple of rounds. Was that because of lab work?
Yeah, she had like a acute kidney injury.
Okay.
Her potassium was not super elevated, was a little elevated, and we're not getting serial labs, so theoretically she could have been hyperkalemic, and that's why we're doing it.
Okay.
Yeah, it's cardioprotective, but yeah, ACLS is a nice guideline to have with cardiac arrest, but just referring back to the H's and T, PA arrest, you gotta intervene on whatever you're more concerned about or potentially could be concerned about. So in that case, hyperkalemia is what I was concerned about.
The left side of her neck, is that sub-Q emphysema?
No,
Or is that adipose tissue?
that is the cooling blanket actually.
Oh, yeah.
So I know that this is all, this is all normal.
That's a blanket.
It's a good look, it's a good to interpret and be like, hey, that's not normal, but that's actually the cooling blanket, yes.
In terms of the drop in blood pressure post intubation, is that considering that her hypertension possibly being from the congestive heart failure, is the drop in blood pressure post intubation concerning or typical?
No, for her it's very concerning. For her
Okay.
it was very concerning. Typically when we intubate someone, yeah, I mean, you can get this transient hypotension. Anytime you're manipulating the neck, you can stimulate the carotid bodies, right, which can lower heart rate and blood pressure. Anytime you're giving RSI meds, even though etomidate is supposed to not affect hemodynamics, it can, it has some suppression of the adrenal glands. Certainly with people with normal functioning adrenal glands, it usually doesn't do anything, but it can still suppress and cause some hypotension. So for her though, this was an issue, and
So was it determined? Was it the RSI itself that caused the hypotension, or was it her condition after being intubated?
I think it was her condition. So to kind of get ahead, I'm concerned that she had some cardiogenic shock, which again is why I called the CICU. When you suppress any sort of catecholamine and you're pushing her the other way. Right now she's in like a stress state where she's just her heart's trying to pump as best as it can, and she's trying to oxygenate as best as she can, and she can take that away. A normal heart can kind of recover and certainly give norepi and other things to kind of help it recover. A heart with diminished EF, severely diminished EF, is just not going to recover, and you can put yourself behind the 8 ball and have a peri-intubation arrest. And this isn't the first time I've seen it with a patient with presumed cardiogenic shock or pericardiogenic shock, right? When she came in, we had like 50 cuff reads. Her systolic was like 180 to 200.
Yeah.
And then she started tiring out, and she started not oxygenating as good, and we had to give her an airway, otherwise, she would have just died with that. And looking back, could we have given her some push dose epi or something around the intubation? We could have. It might not have been a bad idea. I don't know if it would have prevented the arrest though. So these are very difficult patients. These are very sick patients. They're not they've got multiple things going on, so they're not straight, it's not just straightforward CHF exacerbation or straightforward pneumonia or straightforward COPD exacerbation. It's multiple factors working against them. So looking at that X-ray, she had a pneumothorax. After some time of being in the emergency department, decompensated again, started on oxygen while became hypotensive, had intermittent episodes of bradycardia and then hypertension while on the norepinephrine, almost like a paradoxical situation. At the time, I mean, she had bilateral breath sounds when we intubated her, but then, you know, when she started to essentially brady down to be pulseless, we had to, you know, think about what was going on. I mean, she was in PEA arrest again, and that pneumothorax essentially turned into a tension pneumothorax. So we had to needle decompress and put in a chest tube, which she rebounded after that. But again, it's always something to consider, you know, post compressions. You go through your H's and T's of PARS with tension pneumothorax being high up there. I spoke with the cardiologist that we had at Southern Maine, Dr. Ashburnell, and she agreed with me. I mean, you know, the fact that the patient went from tachycardia to bradycardia and remained bradycardic, you know, even after resuscitating is concerning for cardiogenic shock. And so, in addition to the norepinephrine, we placed the patient on dopamine, or you could use dobutamine. I mean, there's multiple pressors that give more positive inotatory, more squeeze. And then they recommended head CT of the chest to rule out a large blood clot that potential to cause cardiogenic shock. Start the patient on antibiotics for possible bilateral pneumonia. And then after talking with the daughter, she wanted the patient to be DNR at that time, so if she arrested again, we weren't going to do anything. This is the repeat. This is just the repeat with the chest tube. Still has some air in there. You see, this is called a deep sulcus sign. So, in a supine patient, you know, the air kind of moves anteriorly right, and it kind of pushes the diaphragm down. You can see this pocket of air there, you know, compared to the diaphragm on the unaffected side. So this is the CT scan we did, and this is just to kind of show you what her lungs really looked like. So that's the tube, obviously. You know, all of this kind of increased white. You can see there's an effusion there, a large effusion, and just like damaged parenchyma on this side. How do I? There we go. Damaged parenchyma on this side, and that's just all fluid. There's no pericardial effusion on the scan. I mean, usually you can see, and there's no blood clot either. But you know, when you get down here, if you see kind of a strip, a dark, more hypo attenuated strip, you can get worried about fluid.
That large black area is the pneumo?
This is the pneumo, yeah. So even with the tube in, there's still some air there, but you know, it took the tension off. I mean, you get tension pneumothorax, you know, it's pushing on the heart so it can't pump, but it's also pushing on the IVC, so you're not getting blood back to the heart. So once a little pressure is off, it's enough to get, you know, blood pressure back. And so this is actually the patient's official echo, because I don't have any of the bedside ones recorded, but this is essentially what I saw. And so this is like a substernal view, or I'm sorry, this is a subxiphoid view. This is the right ventricle, this is the left ventricle, this is the pericardial space, this is the left atrium, that's the right atrium. And so what you see here is the right ventricle squeezing. You can see this little squeeze here. There's a trace amount of fluid, that little black stripes, it's a trace amount of fluid, which I would call physiologic pericardial effusion. So there's a little fluid between the the heart and the pericardial sac, but that wouldn't cause any sort of tamponade. That's just there. And so, you know, that's one thing we looked for when she first came in. But if you notice, this left ventricle really isn't squeezing. You see how that's coming in? That wall's collapsing, it's pushing down. This wall isn't doing anything. You know, it's kind of just sitting there. And so you look at this, and I'd estimate she had an EF of 15 to 20%. You know, and in the clinical presentation of her respiratory distress and you know, decline with bradycardia, you know, she went into cardiogenic shock. I mean, that's just what it is.
How do they determine an ejection fraction from an echo?
So they measure, there's this fancy calculation they do, but essentially they measure the space of the left ventricle in systole and diastole, and then they compare that space to, like, they literally have like a tracer on the echo. They trace it out and it measures the space. And then you'll read on these echo reports, it's like method of discs or whatever. It's just a calculation they do, the percentage between diastole and systole. And so you can, you know, figure out if there's a diminished EF, if there's not a significant enough change between systolic and diastolic volumes. So before we get into kind of what, you know, the hospital course of this patient, let's talk a little bit about respiratory distress. As we've mentioned, even with her differential, I mean, there's a lot of things that can cause respiratory distress. It's not just primarily pulmonary or lungs, but it certainly could be with COPD or pneumonia. Cardiogenic shock or CHF, primary CHF, certainly could be a cause, metabolic. So, you know, someone in DKA, I mean, they're technically, even though it's metabolic driven with their Kussmaul breathing, they're still in kind of a respiratory distress state. Or any sort of acidosis, metabolic acidosis can cause somebody be in a respiratory distress state. Inhalation injuries, any sort of toxins, and then certainly trauma that can cause pulmonary contusions or hemothorax can cause respiratory distress. Again, just to kind of have this up, the main EMS protocol, I mean, you know, the recommendations that you guys are all aware of with respiratory distress, bronchospasm, you know, with steroids, nebulizers. You know, one thing I did want to mention here, and you know, anything that can decrease the preload, or someone has predisposition to preload decrease, which, you know, they mentioned up here, phosphodiesterase inhibitors, such as Viagra and things like that. I mean, you want to avoid nitro. I would echo anybody with concern or history of, you know, pretty diminished EF. I mean, you want to be careful with that too, or bad aortic stenosis, because they are preload dependent. And if you can manage their respirations without giving them these interventions, let's say someone has a known history of aortic stenosis, severe aortic stenosis, if you decrease their preload too much, they're not going to be able to get enough blood through their narrowed aortic valve, and, you know, they could syncopize or, you know, dump their pressures, and it's just something to be aware of. You know, in this patient, she came in hypertensive, and, you know, we were doing everything we could to try and really prevent intubating her, and in the end, she needed to be intubated anyways and arrested.
So Doc, a common practice for us is almost, I don't know about always if it's dry, but if they've got wet lung sounds and we're putting them on CPAP, we typically put transdermal nitro across their chest.
Yeah.
Are you saying that we should move away from that?
I'm saying if it walks like a duck and quacks like a duck, then, you know, keep doing it. History of CHF, blood pressure is 200 over 100. They're wet. You got the BiPAP on. Keep doing that. If they're wet and their pressure, I mean, again, this patient had multiple things going on. As once we get to the hospital course, I mean, she was in cardiogenic shock, but she also, it was sepsis driven, like she had an infection, so there was different components going on. But if somebody's pressures are low and they sound wet and it's known that they have a history of diminished EF, like I would avoid the nitro. I would avoid it, especially transdermal.
because you can't control it. I know it's quick to put on, it makes sense to do that in a lot of situations, but.
Yeah, when you're looking over what Goodman's Mills or Waterboro, whoever brought her in, when you said that they put her on CPAP, the first thing that came to my mind was you said she had very wet lung sounds and they put her on CPAP. First thing that came to my mind was put nitro on her chest.
Yeah.
Not judging them, just
Right.
thinking about how I would treat it, and that's.
And that makes
So
sense.
she has a high pressure at that
Well,
point.
they claim she had
They
low
claimed she
pressure.
had a low pressure. Once she got to her apartment, she had a high pressure. She
Gotcha.
had for like an hour or however long before we ended up having to intubate her, an hour or two. It was, and so I can't access their incident reports, but I don't think they gave her any nitro. I'm pretty sure they did. Go ahead.
On this patient, would you, if, say they were hypotensive in the beginning, would you recommend, starting them on pressors quickly in the field?
Yeah, actually, if sometimes it's hard to get good stories, right? From family or the patient themselves, but if there's a history of pretty bad cardiomyopathy, EF 15 to 20%, and they're hypotensive and wet, yeah, that would be the answer. I would start them on an epi drip if you can, peripherally. I mean, Norepy would be ideal, but they both cause. So there's a little debate in the literature, and we're actually not going to go into this. For a long time, epinephrine was kind of the go-to with that, because it has maybe a little bit more positive inotropy than Norepy. They're very similar. They both cause vasoconstriction and positive inotropy. But over the last couple of years, there's been some studies that suggest Norepy would probably be better. But honestly, I don't think it matters that much. But if you have Norepy, quicker, then sure. But yeah, I would. I mean, and if you had any questions, you certainly could call Med Control, and maybe some of my colleagues would say, no, don't. But, I think you gotta do what's best for the patient, and, if someone's in respiratory distress and their lungs are wet and their pressure is low, tanking them with fluids is gonna make their respiratory distress worse. They're gonna be tubed. And, if you do other interventions to get that fluid off, they're gonna drop their pressure. They need positive inotropy, so.
Would a mix of, now, I guess we'd really only have this amount of time with the patient if we're going north, but after starting them on pressors, getting their blood pressure up to a reasonable pressure, because they started as hypotensive, would we continue to stay away from nitro and not worry about it? Or if we get the pressure up, would we want to start nitro to try and start pushing the fluid back out of the space?
So I would first, what's gonna help them in the more immediate time is the BiPAP or CPAP, any sort of inspiratory positive pressure to push the fluid out of the alveoli. Nitro really, it decreases preload, so it takes pressure off the heart, which is great. But, it's not gonna help the respirations as quickly as the BiPAP or CPAP. So I actually, if you could, say you start them on pressors, peripheral pressors, you get them to a MAP of 65, and you have them on BiPAP and they're doing okay, I would just leave it like that.
Leave it like that?
I wouldn't jump to nitro if you can avoid it. Because you're only gonna, it will take pressure off the heart, but it's gonna have more of a negative effect on their blood pressure than the CPAP or BiPAP would. Unless you had super high inspiratory pressure, super high PEEP, then that's gonna, again, increase the intrathoracic pressure, which is decreasing IV return, or IV, inferior vena cava return. But I would do the BiPAP first. Now, of course, if they're still having horrible respiratory distress with that, you need to move, forward. I mean, you certainly could try it, but it's probably not going to work. You'll probably need to be intubated.
Okay.
You guys have other questions or thoughts? All right. We'll just talk really quick about pulmonary edema, COPD, stuff like that. So, I mean, there's two main types. I mean, it's fluid in the lungs, obviously, you know, filling the lung parenchyma. There's cardiogenic versus non-cardiogenic. Cardiogenic, obviously, you're not pushing the blood forward enough, it's sitting back, it's causing hydrostatic pressure, which is bleeding the fluid out into the lungs, usually due to left ventricular systolic or diastolic dysfunction. Either one of them can cause it. Non-cardiogenic is usually due to lung injury, which then again causes the increased permeability of the cells. Kind of like we talked about with the cerebral edema. I mean, if there's an inflammatory process going on, all those cytokines, all those inflammatory markers are telling the cells to increase permeability and fluid leaks out. And this is, you know, so with the non-cardiogenic, it usually does present as you know, ARDS or acute respiratory distress syndrome, which I know all you've heard of. You know, the definitions really, I don't think matter that much for you or I. I mean, this is more for the ICU stay with the hypoxia, having normal ventricular function, which pretty much is saying, hey, this isn't due to the heart, and then the obvious diffuse alveolar infiltrates that you can see with this chest x-ray. More times than not, it's caused by sepsis. Again, an inflammatory response. Somebody's sepsis is so bad enough that all the cells in their lungs are just, you know, essentially in a crisis mode and are leaking everything out. It can also be due to trauma, near drowning, aspirations. You know, you can get flash pulmonary edema from opioid overdoses too. There's debate as whether or not that's due to Narcan or opioid, but either way, pancreatitis, there's a number of things that can cause this. The treatment's just supportive pressure, you know, supportive care in what we're typically doing anyways, right? Trying to get the oxygen saturation up, trying to adequately ventilate them if we can. You know, from a ventilation standpoint, I mean, you really want to do low tidal volumes to prevent any sort of barrel trauma. You know, all things we know. Long-term, proning patients can improve oxygenation. Again, this isn't something you or I are really going to have to deal with. But I mean, that's what they were doing a lot with these sick COVID patients. That's why they were proning them. Moving on to COPD. You know, it's a chronic inflammatory disease, as you guys know. I mean, it's the breakdown of the walls and the alveoli cells, leading to these large dead areas of the lung, which limits airflow in, but it also limits airflow out, which is why they retain CO2 because they can't ventilate. They also have a diffuse inflammatory response, but it's more chronic in nature as opposed to acute. And they have significant disease. I mean, usually it's due to smoking, significant tissue destruction due to smoking. They can have permissive hypoxemia and hypercapnia. They can develop pulmonary hypertension, right? Because the air is not moving through great, which means there's increased pressure there, which then is put on the vasculature, and you get this pulmonary hypertension, which puts them at risk for a whole slew of things. Polycythemia, increased production of red blood cells because their body's not getting enough oxygen, so it's trying to increase the red blood cells to increase oxygen delivery. So it's stuff we all know, you know. Main treatment, nebulized treatments of beta agonists, anticholinergics, similar to asthma, right? Same with steroids. And then non-invasive ventilation always helps us avoid intubation if we do it early enough, and if they're not super sick or have other things going on. Because the other thing about this patient that I forgot to mention, she did have some underlying COPD that was later disclosed to me. I mean, she got the kitchen sink thrown at her. So with this CT, I mean, so these are bad lungs, obviously, right? It's a bad COPD patient. Specifically here, what are those? Do you know?
Strapped air.
Strapped air. If they're big enough, you know, we call them bleps. You know, smaller ones, it's like, all right, it's tissue destruction, breakdown of the alveoli. It's just diffuse emphysema is what it's called, right? And contributes to COPD. If they're big enough, they're called bleps. And the reason it's good to know if someone's a very bad COPD and they have these blebs, sometimes you don't hear any air there, and you could think they could have a tension pneumo or something. You put a tube in there, you're screwing the patient. You got to be extra careful with these patients, because I've seen that done before in residency, and a tube got placed, and they actually developed a tension pneumo, and then required, arrested and required decompression, intubation, all that stuff. So I just wanted to point that out, with these really, really bad COPD patients, they get these blebs, and it can mimic a pneumothorax, and you just gotta second guess it.
Are those gonna be present during the exacerbation of their COPD, or do they always have that?
They always have it.
Okay.
They always have it, so if they're in exacerbation, and you notice one lung it sounds more diminished than the other, it could be a bleb, and so if you're able to oxygenate them with BiPAP, and steroids and nebs and all that fun stuff, I would just do that. I wouldn't like jump to like, oh shit, there's a pneumothorax. I wouldn't assume it. I would.
Is that why we're told not to decompress until it turns into a tension?
Yeah, actually, yeah. So this EKG, is obviously irregular, and it's something else that's associated with COPD. Does anybody know what we're looking at or what this could be?
Weird P waves, where
Yeah.
the arrows are.
Weird P waves, yep. These arrows are saying, hey, each P wave has got a different morphology, and there's P waves present, right? So it's not AFib.
Is it like a traveling pacer?
No, it's an arrhythmia that is very specific to COPD patients.
If I put this in the computer, I would hit regularly irregular.
Yeah. Yeah, that is probably what it would read as. Multifocal atrial tachycardia. You guys familiar with that at all?
Heard of it.
So, the only reason I'm bringing this up is some of these bad COPD patients can have a very regular EKG, and like if you're not really looking for the P waves, you might say, hey, it's AFib, but it's really this, and it can happen over time. Essentially, that because the heart's not getting oxygen long term, the conduction system is just not working as well as it should, and it's not AFib because the signal is still coming from the SA node. That's why they have the P waves, right? But it is an irregular arrhythmia that can lead to patients again having worsening of symptoms or not perfusing well enough. And so instead of treating with rate controlling medication that you may do with AFib, the treatment really is just oxygen. I mean, by definition, it's 3 or more P wave morphologies, and you look here. I mean, this one's kind of small, this one's kind of skinny, that one's inverted. Like you see something like this, and you see a couple P waves that look funky. It's just something to think about,
Would that be a diagnostic tool for COPD? Could we use that and
Yeah.
say, okay, I think that this is COPD, and then look at that and see?
Yes, this is COPD specific.
Okay, cool.
This is just long-term stuff for COPD patients, smoking cessation hormone too. I mean, we see so many of these patients. What'd you say?
So much to tell the patients that.
Yeah, they don't want to listen. They all smell like ashtrays, right? So, unfortunately for this patient, this is the cardiology note from our cardiologist. Saying, yeah, she's in cardiogenic shock. They estimated the EF at 32%. Pretty sure her subsequent echo demonstrated a more diminished EF. But either way, they just recommended the typical cardioprotective things with aspirin, beta blockers, statin, heparin, and the notice of patient being made DNR. And this is the discharge summary. And so she was admitted. Later found out she had some pulmonary sarcoidosis. there's essentially a decision after she had no good neurologic recovery to make the patient comfort care. And this actually was like a really, really sad case because I mentioned earlier she kind of all of a sudden got short of breath. What really happened was she took care of her adult disabled son, who was a primary caregiver, and she never really took care of herself. That's why some of this stuff was kind of undiagnosed, this lung mass and even the sarcoidosis. And so the reality was she probably developed the pneumonia that over the last week, several weeks leading up to this respiratory distress, became septic, did not report it to anyone, including us, and she's like, I felt fine. And then all of a sudden, it put enough strain on her heart that put her into congestive heart failure and then cardiogenic shock. And so when she came in, they actually, somebody else picked up her son who came in and it became like a case management placement situation. She was the only one who cared for her son. So it's a pretty sad case actually, but she was complicated, so it was a good case to go over. You guys have any questions? Yes?
So I've heard of some difficulty breathing patients going and they end up using heliox instead of oxygen. What's the differentiation between why would you go to that for certain people?
So heliox is good because it's lighter weight, and it's good for upper airway compromise or obstruction, so that's why sometimes we use it with bad croup patients. There really is no literature to suggest that it works better, but clinically, if the patient isn't doing well, I would try it. And we did actually, when we did the RSV croup talk a few months ago, one of the patients I had that had RSV, bronchiolitis, and croup, we ended up using it to try and prevent intubation, which we were able to, thankfully. But that would be the indication. Someone with really bad lung parenchyma, lower lung issues, you can use, well, first of all, you could do ECMO if they're that bad, but ECMO is really just used to bridge someone, it's a temporary thing, right? You're bypassing the lungs and oxygenating the blood. So it's not a long-term thing. Neither is heliox. But you could also use nitrous oxide, which opens up the alveoli, but that's not something we have at Southern Maine. I'm not sure if they might have it at Maine Medical Center though.
Is there nitrous? There's no nitrous?
No, I don't think at Southern Maine. At least not in the emergency department.
I only see one ambulance in the area.
We used to have it.
Yeah, but people
I know.
move fast.
I know it used to be more common
With-
where I work. So
With hindsight being 2020, is there anything EMS for the hospital could have done differently in treatment to improve outcome? Or?
I think if we, yeah, I mean, I think if we did some pressors, peri-intubation, or even early on, potentially we could have changed the course of her situation. The only problem is it really wasn't evident when she first came in that she wasn't in shock. I mean, her pressure was high, and then she kind of went into shock. It was like witnessed before our eyes. This what transpired. EMS wise, I mean, I think they did I'm pretty certain they didn't give nitro. I think they did, the right thing, trying to oxygenate her as best they could. They did give a neb. I don't think they gave Decadron, which probably would have helped. But she sounded wet, which is why I think they didn't do that. I don't have the report, but from what I remember, because this was a year ago. So in hindsight, those are the things that may have made a difference. But the reality is she was very sick, and
She's basically odds at that point. So there's not really much we're gonna do with that.
yeah,
Once you hit that benchmark, it's kind of.
this is a high mortality rate. Yeah, and it's just an unfortunate case where potentially if she came in earlier, or but she was taking care of her son. So, any other questions, or I think, yeah, if you guys have good cases, I mean, I try and ask around too with the docs at Southern Maine if we can get good cases. But cases that go to main med, directly to main med that are good cases, we can do those too. The next one we do, we can just do shock unless we, you know, we want to do another theme or something else. I can compile it and we can just go over whatever you guys want, and however you guys want to. Is this kind of presentation work for you guys? Or? Okay.
I think it's difficult for us to send you cases that might be good because we don't know what cases turn out to be good. We take in, you know, we've done 800, almost 900 calls this year. I have no idea if any of the patients we've taken in turned out to be anything significant.
Yeah, and that's a good point. I think ones that you think might be significant though aren't a bad idea. I mean, there was a potential aspirin overdose I think that came in one time, and the patient ended up having appendicitis, and so yeah. Yeah. I think that's pretty certain it was.
Rung a bell.
Because I wrote down the E number. I was like, oh yeah, aspirin overdose. That's great. And I didn't see the patient. Someone else ended up seeing it.
Yeah,
and
I
then
actually told you.
You did tell me. I remember it. I was like,
He'd been taking like 20 aspirin a day.
Yeah, it
for
was like
6
an
months or
insane
something.
amount of an insane dose for an insane long time. And like we called poison control and we're like, hi. This guy's been taking like a bottle of aspirin a day for 8 months. The fuck?
yeah,
You know?
I mean, you can get chronic overdose from that, which is a lower threshold of initiation of emergent dialysis. But yes, I forget who saw it. I was like, oh hey, you know, how's that? He was like, oh, they have appendicitis. I was like, oh, I don't know. So.
This
It happens. No, but you never know.
Well,
Like,
no,
that's
we brought up the novel thing.
Well, yeah.
Yeah. And then he told us about his aspirin habit. and
Yeah,
we
I
just
think
assumed that was it.
you asked him like, how long has this been going on? And he was like, well, the pain comes and goes, so I've been taking aspirin
Yeah.
every day. And you were like, well, for how long? And he was like, yeah, 8 months. We're like, how
That's
much
heavy.
aspirin
No, that
have you been
puts you-
taking? He was like 2,000 milligrams. We're like, holy shit!
That's fine. You had a question?
Yeah, we find out about a patient, it might be a good case study, we just had one on Friday, because we wanted to ask you about it.
Yeah.
Friday morning, we went to Maine Med Direct, he was having a stroke right in front of us.
Okay.
We can give you the, that might be
Just send me
something
that.
to go over.
Yeah.
Send me the
Did-
info and I'll get it, the call.
Yeah, just- Yeah, and I think, yeah, because there's that email, I want to hear about all potential good cases. If they end up not being good, we don't have to do anything about it, but
We went right to CT.
you guys carted them right to CT.
Yeah.
Did the physician there show you, what'd you say?
It's like a 3 millimeter, either, they couldn't tell if it was a mass or a bleed.
Oh, okay, so they didn't get a thrombectomy. Then it wasn't like a massive thrombus in the MCA that they could go in and get. It was a bleed.
Well, we did not put down for that